Yep,
Do you see that
perfect.
okay?
Yep, perfect.
And if I do that, does it go to presenter view or is it
It
normal
go
view?
it goes to presenter view.
It goes to presenter. Okay,
Yeah.
fine. We'll just do it the old-fashioned way.
Yeah. Maybe yes. I think yeah, that's perfect. It looks fine to me.
Perfect.
Okay. We have other faculties as well. Welcome. Jakobus there and Rakesh there.
Thank you, Jay.
All good. You managed to join. I'm very grateful for your presence. Welcome back. I'm sorry we need to cut short the coffee break, and now we have a Chris Thompson. He's a consultant pediatric ENT surgeon from Edinburgh, and Chris doesn't need any introduction. So, Chris, over to you, please.
Fantastic. Yeah, thanks, Jay, for the invitation to speak today. It's been a fantastic day so far. You've done a great job in building what is the 8th iteration of the course now. So I'm Mr. Chris Thompson. I'm a consultant in paediatric ENT and airway surgery in Edinburgh and NHS Lothian. The photo that you see there is one of the rare days that we've actually had sun in Edinburgh. So everybody obviously rushed out with their cameras. But it really is a beautiful place that I've been able to call home for quite a bit now. There are lots of things going for Edinburgh, steeped in history. And you can see the castle in the top left-hand corner there, the Royal Mile, Victoria Street, and of course the Edinburgh International Festival, where the population triples in size. And we have a lot of cultures and different people from around the world descending. Also have Arthur's Seat in the middle of Edinburgh, which is very picturesque. And despite the Scottish weather, managed to go on fire this year. So we're hoping to avoid anything like that when it comes to airways. We also have the Royal College. We're fortunate enough to have the Royal College of Surgeons of Edinburgh. And this is, of course, an institution steeped in history that have been very supportive of the course over the years as well. A little bit about me. I work at the Royal Hospital for Children and Young People. This is a fairly new hospital that was purpose-built. We have a PICU, an airway service, and we're really developing the endoscopic airway side of things. I was fortunate enough to train up at Ninewells with Jay and Sam as well, who I think is here. I think we probably both agree this is the best, probably Ninewells' best angle. And I also completed a post-CCT fellowship at Alderhay Hospital as well down in Liverpool. So I've been very fortunate to be able to gather a lot of airway experience from all over the country, really. So when I was putting together this talk, bearing the audience in mind, I was trying to really distill it down into what would actually be useful. And I think that I've come up with a few different topics, some videos, and maybe to stimulate some discussion and thought about the paediatric airway. The paediatric airway is something that we are all charged with often covering on call. You may or may not cover it on your on call out of hours. It may be part of your day-to-day practice. But I think we can all agree that sometimes it does instill a certain amount of extra thought, sometimes anxiety. So I hope that I can perhaps help with that today. So we plan to have a look at going back to basics, the surgical anatomy and some of the key differences and some comparative anatomy. We'll then have a look at some physiological differences and actually maybe make sense of why airway surgery in children is a little bit different, with consideration about desaturation, short apnea times, And then we'll move on to some of the more common pediatric surgical airway pathologies, which I'm sure you are all familiar with, but then go on to perhaps offer some management strategies, both in the emergency and elective settings. The syndromic airway is something that makes up a large proportion of my workload, and for anything from trisomy 21 Down syndrome through to the craniofacial syndromes require an extra layer of thought and an extra bit of preparation to ensure the optimal outcomes when it comes to management and airway surgery. So a little bit of comparative anatomy. I think we're all happy that smaller overall size will directly translate to less airflow and more tendency to run into problems earlier. As you can see on the right-hand side, the infant or the child airway is more of a funnel shape, whereas as it matures into an adult, it will become more of a cylinder. It's positioned higher in the neck. It's located at roughly C3, C4 level instead of C5 or 6 as in adults. And that's why when you examine, do an oral examination in a child, you can often see the epiglottis protruding up into the oropharynx. I have been referred this as a foreign body before, so it's important to note that. Speaking of the epiglottis, it is more omega-shaped. It's more vulnerable during intubation, especially if it's retroflexed or particularly malaysic. And interestingly, the narrowest point in the pediatric airway is the cricoid cartilage, as opposed to the glottis or immediate subglottis in adults. So that also pays to think of that when you're planning out any airway surgery. Overall, general principles would also include that softer, more flexible cartilages with less ossification. So they are more compliant, but they're much more susceptible to injury as well, much less hardy. And when it comes to the glottis itself, the shorter and thinner vocal cords with less defined musculature does have a functional impact on voice and airway tone as well. This is perhaps a little bit better demonstrated in these diagrams. You can see quite clearly on the right-hand side the more funneled shape of the pediatric airway that sits higher in the kind of the pharynx compared to the adult on the left-hand side. We can see why this is potentially a bit more of a challenge when it comes to intubation, airway surgery planning, or even things like foreign body aspiration. You can imagine if there's a syndrome thrown into the mix as well with some micropneia, this could become particularly difficult. So physiologically, children are a little bit different, and it does pay to think of them not just as small adults in that case. They have a higher oxygen consumption, a lower functional residual capacity, which can lead to more rapid desaturations. And they've got immature respiratory control. Their respiratory centers aren't as well developed as adults, and this does increase the risk of apnea. Another thing to consider is an increased vagal tone, which can lead to bradycardia during airway manipulation, and it pays to keep the lines of communication very open with the anaesthetist with regards to this, as you may need to stop or even sometimes even abandon an operation. With regards to operative management, I thought that probably post-operatively things might change a little bit more. So because of the sheer size of the airway, the risk of edema or obstruction does increase, especially if you manipulated the airway, performed an operation. So having some kind of backup in terms of HDU or PICU monitoring is often required, often more than in adults. Humidified oxygen, nebulized adrenaline, or steroids in particular are useful adjuncts, and I use post-operative steroids for 24 hours or so quite regularly in my practice. And a low threshold for reintubation or tracheostomy if the airway patency is compromised. Unfortunately, these children do restenose or have scarring or granulation tissues, so you do often have to either follow them up closely or even repeat the procedures as well. So a little bit of a difference in the post-operative side of things. So moving on to the key surgical airway pathologies. I'm sure that you have all come across this in your practice, but laryngomalacia, subglottic or tracheal stenosis usually form the bulk of my practice, but also vocal cord paralysis, and congenital neck masses as well. So laryngomalacia, it is the most common cause of infant stridor. It is often appears in clinics, especially if pediatric practice is commonplace. And management really depends on a number of things, including the severity of the symptoms, but actually one of the overall arching principles of pediatric airway surgery is failure to thrive. So really important to have a look at during almost any pediatric airway condition, how they're doing. Have a look at their centels. Are they falling off their centels? Are they feeding well? Because this forms a key aspect of our decision-making process. So only 90% of kids that are diagnosed with laryngomalacia don't need any intervention and will just require conservative treatment and follow-up. But actually about 10% need a bit of a helping hand and go on to an intervention such as a supraglottoplasty that we'll discuss a bit later. And I've got a couple of videos to show you as well. Subglottic and tracheal stenosis, particularly tracheal stenosis with the increase in use of microcuff tubes, is on the rise. This could be congenital or acquired. For instance, as mentioned, post-intubation. And this can be managed conservatively, but more commonly, it can be dilated endoscopically. You can employ other techniques such as anterior posterior cricoid splits or reconstruction with more advanced techniques such as LTRs and CTRs. Vocal cord paralysis wise, again, this can be congenital or iatrogenic. When I was down at Alder Hey Hospital, there was a study done on the amount of children that had post-cardiac interventions, and it could be as high as 2/3 of children that have a vocal cord paresis or palsy after this. So especially, it pays to think of that, especially if you know the child's had previous cardiac surgery. Amazingly, kids can compensate very, very well with vocal cord paralysis. Even a total paralysis can be compensated for 100% by the other side, especially if they work with speech and language therapy. But there are other techniques such as vocal cord lateralization and in extreme circumstances, tracheostomy. Congenital neck masses are another consideration, somewhat rarer, things like cystic hygromas, teratomas, or laryngoceles. And these can be managed with surgical excisions, sclerotherapy, or in extreme cases, an exit procedure. So pediatric tracheostomy forms a key part of training in the UK. And we are encouraged for CCT purposes to have done a few at least. And I think there are a few key differences. I'm not going to teach you all how to do tracheostomy. I don't think that would do the meeting justice, but I'm going to highlight the key differences between pediatric and perhaps adult tracheostomy. So I hope this video plays and I can perhaps comment on it as it goes. So there's differing opinions in literature about horizontal versus vertical neck incision. I find that it's good to stick to what you're used to, especially if it's in more of a stressful emergency scenario. It tends to be younger kids that we go for a more of a vertical neck incision, but I'll often do a horizontal incision. One of the key differences you can see here is the fat plug removal, which allows us to get down to the straps and ultimately to the trachea. And what you'll see that here is them making their way down to that stage. So when they make their way down to the trachea, we tend to stay roughly between the second and the fourth rings. And before we make any incision into the airway, we place stay sutures. And these are usually non-absorbable sutures that can help elevate the trachea up and out of the neck if there's any difficulties, but also actually if the tube becomes dislodged post-operatively. These are usually taped to the chest, labeled, and also it's important that you hand this over to the post-operative care team. There is a little bit of difference in opinion as to whether you then proceed to the stomal maturation sutures at this point, or whether you would make your tracheal incision. But stomal maturation sutures with absorbable sutures are also a bit of a key difference, and I tend to use Vicryl for these. So this is them entering the airway, which of course requires key communication with the anaesthetic team. And then the tube can be inserted and secured. Okay, so a quick word on cricothyroidotomy. I know that it's been mentioned earlier today, but it's probably to highlight that this is a rare and last resort scenario in kids. The Difficult Airway Society have got quite clear guidance on this, and it really is in a can't intubate, can't ventilate situation. And why do we avoid this? It's purely due to the size. So there's a high risk of injury to adjacent structures. The cricothyroid membrane in infants is really tiny. But nonetheless, there may be a scenario in which you find yourself or one of your colleagues find themselves, and actually they recommend needle cricothyroidotomy first, with second line being surgical cricothyroidotomy in older kids. But actually, if there's a specialist airway support available, such as ENT, is to go straight to a surgical tracheostomy. And if you do find yourself in this scenario, it should always, again, be followed up with formal surgical tracheostomy as well. So we move on to some of the more common interventions that I perform. Supraglottoplasty is somewhat of an umbrella term for multiple smaller airway interventions. It's always combined with an MLTB or an MLB, and it can include some or all of the kind of following things. So areoepiglottoplasty, division of the areoepiglottic folds, excision of the redundant mucosa, which is usually over the posterior aspect in the arytenoids, and also epiglottopexy as well. It will provide a pretty quick improvement in stridor respiratory function, and most kids show a pretty immediate postoperative improvement in function as well. It's important to counsel that there's a risk of aspiration afterwards, and you can have occasionally persistent or recurrent symptoms, and very occasionally you do have to revise these. So I'm hoping that, again, this will play, but this is a very common finding. Omega-shaped epiglottis, posteriorly being pulled in as well there with the redundant mucosa over the arytenoids, and very tight areoepiglottic folds. Video below shows an areoepiglottoplasty, which maybe you can see is often performed just using cold steel, when you will divide the areoepiglottic folds, and you can see how immediately that really opens up the laryngeal inlet. This one's particularly bloodless, so I'll have to thank Mike Rotter over in Cincinnati for his use of that video. Next video is excision of the redundant mucosa over the posterior aspect of the larynx and the arytenoids. You can see that this is again done with cold steel. And what we do is we approach posteriorly and try and join it up with the previously made areoepiglottoplasty incision. This is the same child postoperatively. You can see that there's quite a significant improvement in the laryngeal inlet, which should be accompanied by a formal MLB to check for no other abnormalities. Okay. So balloon dilatation also forms a large part of my practice, and this is a lot of indications would be subglottic or tracheal stenosis. Could be due to inflammation, trauma, congenital or post-intubation injuries, as aforementioned. Patients unsuitable for open surgical reconstruction can also be managed in this way, and it can also be used as a bit of a temporizing measure before you get to that point, especially in younger children. There is some evidence out there that concurrent steroid injection is a benefit as well, and I think that there's a bit of conflicting evidence there. The advantages are that it's minimally invasive. It's a very short recovery time. You can often get home the same day, and it can, as I'm saying, avoid or even delay opener surgery. Limitations would be that it's often only temporary relief, and restenosis can be common, and you do have to repeat these procedures even within a few weeks. I'll often do a check MLB at 6 to 8 weeks. And there are some risks such as pain, bleeding, and postoperative edema, and of course revision. Balloons are improving all the time, and Mobile Airway Card is a great app that I've included there to help with balloon sizing. Of course, you have to take into account if there's any syndromes or anything involved, because often the sizes don't, it's not quite a one size fits all. The next step in the ladder is reconstructive airway surgery, and I know that Jay is planning on presenting on this a little bit later, so I'll try not to step on his toes too much. Laryngotracheal stenosis again can be form part of my workload, and laryngotracheal reconstruction, either for subglottic stenosis or vocal palsies, can involve either an anterior or a posterior costal cartilage graft. Cricrotracheal reconstruction or resection can be a useful procedure in severe subglottic stenosis, which involves a resection of a segment and reanastomosis. And for long segment stenosis, you can employ a slide tracheoplasty. There is evidence that that the incidence of open airway surgery is decreasing due to an improvement in endoscopic technique, experience, and equipment. But what is apparent that, especially in complex or revision cases, there will always be a role for it, perhaps. I'm going to move on now to syndromic airway. Trisomy 21 or Down syndrome is a condition that we see a lot of in ENT. There are a lot of anatomical reasons why, and this involves both the ears, nose, and throat. But I'm going to try and concentrate a bit more on the airway side of things. Problems such as macroglossia, midface hyperplasia, and small nasal passages can play a part, but also a narrow nasopharynx or hypopharynx with adenotonsillar hypertrophy can also play a part in a multi-level obstruction in Down's kids. Hypotonia plays a part in this, leading to this multi-level collapse and an increased risk of OSA. Considerations during anesthesia or intubation would be a difficult mask ventilation and intubation, and also when we're positioning them perhaps for an adenotonsillectomy, the atlantoaxial instability there. So it is important that a preoperative airway assessment is critical. Smaller devices might be used when the airway is being manipulated or intubated, and there's important that you have often higher levels of care such as HDU or PICU in place. Other challenges in craniofacial airways include generally midface hypoplasia, micrognathia or glossoptosis, or sometimes choanal leading to difficult intubations. Often you can have abnormal laryngeal anatomy, facial asymmetry, or cleft palate and lip as well to consider. And this will all lead to increased incidence of OSA, additional surgery airway needs leading to sometimes tracheostomy in severe cases, but also progressive obstruction. So some situations such as Crouzon's can actually worsen with growth that need to be addressed before they get to that point. So just a quick reminder of some of the syndromes that we deal with and have extra airway considerations. Crouzon's and Apert's, both from the FGFR2 gene mutations, can manifest as craniosynostosis, midface hyperplasia, and proptosis, leading to tracheostomy, as you can see on the left here, or Treacher Collins or Pierre Robin, micrognathia, hyperplasia, and other things such as cleft palate can also impact on the decision-making process, preparation, and ultimately airway management as well. So what are the considerations in the syndromic airway? I think pre-planning and MDT involvement is very, very important. As much preoperative assessment as you can to minimize risk. Things as simple as mouth opening, neck movements, looking at the amount of retromicrognathia they have, and actually, is there a need for imaging? Have they been imaged for other reasons? They can often be very useful adjuncts. Ensuring that airway plans and equipment are in place prior to this, video laryngoscopes, loaded Hopkins rod endoscopes with a tube for airway rescue, and also a ventilating bronchoscope can also get you out of jail, and it pays to double check or even triple check this equipment before embarking on these type of cases. I always like to have a tracheostomy kit nearby with a tube identified. I think this is an important, but hopefully a really last resort. And also I've touched on several times about appropriate post-operative care. These kids will often always go to PICU for a period of observation, and it pays to work pretty closely with the MDT with regards to this. So I've tried to keep this fairly high level and keep it interesting with some videos, but what we have covered is some comparative anatomy and considerations. The key pediatric airway pathologies and their management as well. Some emergency and elective pediatric airway procedures, scenarios, and hopefully some tips there. But also a large part of my workload, which is the syndromic and craniofacial airway and their challenges as well. It does pay to think of children, not just as small adults, but almost their own entity. So I'd like to say thank you and invite any questions.
That's fantastic. Thank you very much, Chris. That's very intellectual lecture for the pediatric airway, which is very challenging, to be honest, to present these things in a short period of time. It needs a fellowship. So we'll quickly look at the Q&A to see whether there's any questions related to that, and then either you can type that questions by yourself and that everyone can see, or you can try to answer one or two questions through virtual as well.
Absolutely, yeah, no problem at all. I'm just having a quick look at the chat. Doesn't seem to be any questions there. Very happy to share my email or anything, or I can answer anything real time as well.
Brilliant. That's fine. I think thank you very much, Chris. I think you're good to go. I'm very grateful